So good morning, everybody, and thanks for coming so early. I think it's good we were a couple minutes late because I think our participation increased about 50% in that 5 minutes. I just realized there's no clock in the room, and I don't have a watch on, so if you could help me out, that'd be great. Thanks.
Now mine's an hour slower. So I didn't check.
That's helpful then. Okay. So what I'll talk about today are solutions for our sciatica, hip pain, and back pain, and specifically talking about diagnosis and treatment for the lumbar spine, the sacrum, and the pelvis. And a lot of these things can be a little bit complicated, but in the lab, I'm going to kind of simplify some things and give you some take-home techniques that you can do very, very easily on your patients, even without very specific diagnosis, that will help to mobilize these areas. So we will discuss just a review for you of lumbo, pelvis, and sacral mechanics, how these things move, and what the sort of lesions and somatic dysfunctions are that typically occur here. We'll discuss origins of pain that occur in these areas that patients will commonly present with, especially in primary care. We'll talk about a little bit about an autonomic dysfunction that's involved with these areas. And then I'll talk specifically about the somatic dysfunctions that we see, what the mechanics of those lesions are, how we make a diagnosis, a palpatory diagnosis, and what we'll do to treat that. So just to kind of get an overview of the anatomy, the most important thing I always consider first is the fascial strain that's present. You need to consider what's happening fascially with the patient. So you have your lumbodorsal fascia, and that will sort of invest tissues that kind of come from everywhere, every extremity, every part of the body, the rib cage, your thorax, your anterior abdominal wall, and of course your lumbar spine, pelvis, and the sacrum are right there. So small discrepancies that happen mechanically in the lumbar spine, pelvis, and sacrum will transmit these forces everywhere else in the body very easily. So it's really a lot of bang for your buck when you address this area, even if you've got, say, a shoulder complaint or a lower extremity complaint. When you consider the way these fascias are tied into the entire body, it's really easy to see how addressing the lumbosacral pelvis area will help normalize these fascias and can help normalize tissue tension that's getting transmitted throughout the body. So I always kind of keep the image of sort of this guy in my head when I'm treating the patient and remember the direction in which those fascias are running and what the anatomy is underneath my hands. So trapezius is going to come up and you're attaching to your entire thoracic spine, cervical spine, all the way up to occiput. But you also have the upper extremity because of the attachment to the scapula. And then it'll even reach around and attach onto the clavicle. So you can have anterior complaints or cervical complaints or things that you wouldn't necessarily think of tying into the back. But through trapezius, this happens very easily. Latissimus is going to tie in your lower lumbar spine in with your upper extremity because it's going to attach right up to the humerus. So I always consider what kind of the directionality is there that's happening when I'm treating the lumbar spine. Serratus posterior inferior will tie you right in with the rib cage. I don't have a pointer, but you can see over here on the right. You've got the lower rib cage 9 through 12. And then the lumbodorsal fascia, as I discussed, is going to tie you in throughout the lower extremities and reaching all the way up into the upper extremity. So this area is going to be very busy as far as what it is responsible for and the tensions that it will transmit in all these various areas. And of course, this is very commonly lesion because of postural mechanics that are faulty or strains that people have walking upright that are chronic. But when you get an acute strain, it may get a little bit more symptomatic. So this is a sort of a stabilization mechanism that's set up in the body, fascially and with the muscles in this area that help these mechanics to work properly. So your lats are going to cross over with your gluteus maximus, and I think these photos show really well what those stabilizers are like. It's like a giant X in your back, and that'll kind of tie in your lower extremity with the contralateral upper extremity. And so I'll talk a little bit about what happens, if you have a patient coming in with a chronic shoulder complaint and you're treating the shoulder and you're really not getting any result, or it gets better and it comes back. Sometimes you've got something either in the contralateral lower extremity or, as I mentioned, in the lumbodorsal area that needs to be addressed that you wouldn't necessarily think of right off. But if you remember these mechanics and the fascial and the muscular arrangement here and these stabilizing forces, it's really pretty intuitive to kind of think about what's happening in that contralateral lower extremity and address that that, and that can release a lot of the strain and the tension that's pulling on that upper extremity in an abnormal way, causing the faulty mechanics to begin with. And then you've got your hip adductors and abductors that will also work in sync to stabilize the lumbosacral pelvis area. And then your abdominal obliques will cross over with this sort of X-shaped pattern too. So just keeping those things in mind when we treat will kind of help you diagnose as well as treat what you have going on in the patient. So you also have to consider the ligamentous system, and this is kind of a complicated sling system in the way that the pelvis and the sacrum are connected. So you can get laxity on one side in the ligaments and tension on the other side. You can get strains that occur in the ligaments where they'll get pulled abnormally, and then you've got a chronic imbalance that's set up that needs to be addressed. A lot of times these can heal very quickly if you reestablish the bony mechanics. And we'll address a lot of times the ligamentous system specifically and rebalancing the ligaments in this area to help allow the bones to then kind of reset into a neutral position. So you want to kind of consider this picture in your mind, because we'll be doing today some balanced ligamentous techniques that are really simple, but that just help restore the normal balance that you have between the pelvis and the sacrum. That's kind of what I wanted to say there. So when we think of the principles of tensegrity, it kind of ties in really well with what we're doing in the pelvis and the sacrum. In tensegrity, you can see in the structure, all of these bars are held up together as one unit, and there's one string that kind of transmits throughout the entire thing and suspends all of these bars up in space. So there's 3 contact points with the ground, and if you were to pull on any of the string in any of these different areas or move any one of these tubular pieces, which could represent the bones, you would affect every single other part of this structure with that motion. You can't move one little item and move that string without all of the rest of the string moving and all of the rest of the tubes moving, because it's completely connected. And this helps us remember what's really happening in the fascial and ligamentous tissues in the body, because they are all completely connected. There's no stopping and starting point where a ligament or fascial tissue will end and then it picks up again in the next muscle. And we learn in anatomy, we do compartmentalize and kind of segmentalize the way that we learn things. So you've got this one muscle over here, this muscle over here, this fascial band over here, and it's very separate. But we know that's not really how it exists in real life, and that all of these tissues invest directly into each other. So the fascias are completely continuous, just the way this string is continuous, or this wire is continuous throughout this entire structure and holds it together and allows it to have that suspension. So these structures are held up in space, just like our body is held up in space. It's not only through the work or the effort of the muscles to hold us up. There's actually a balance in the ligamentous system that can allow us to relax in a standing position and have a buoyancy and a lifting to hold us upright. And that goes awry in multiple ways and can cause a lot of problems in the system. So when we address the ligamentous system and the fascial system, it's important to remember that. So our palpatory diagnosis, we will palpate right over the pelvis. The PSIS's posterior superior iliac spines are pretty prominent, and sometimes they can be more difficult to find. In certain patients, if you have the patient bend forward and flex, they can become more prominent posteriorly and more easy to palpate. But you want to palpate that and get a sense for how the innominates are lined up in space relative to one another. Your iliac crests are another landmark you want to palpate. So is one higher than the other or lower, and to kind of diagnose what you think is going on in the pelvis. The ASISs are not shown in this picture. Anterior superior iliac spine, same thing. You'll have the patient either standing or lying on their back, and you'll palpate over these areas to see if there's a little bit of a twist or an abnormal position of the pelvis. Your sacral sulci are going to be just medial to the PSIS. So we're shown here, and you just need to roll your thumbs in a little bit medially, and it should dip into a little space. So you want to diagnose there and feel what's happening in the sacral sulcus. A lot of times patients come in with low back pain or even hip flexor problems that are going on, and these are tied into the lumbar, the pelvis, and the sacral mechanics. It's really helpful to get a diagnosis on what's happening in the sacrum, because this can throw off the entire lumbar spine and cause chronic or severe low back pain. And addressing this, as I said, it's like a lot of bang for your buck just addressing that one little bone, because of how it ties in with all of the lumbar mechanics and the pelvis mechanics and everything else that's going on in the area. So it's kind of a cornerstone bone to address. So your sacral sulci will tell you the position of the base or the top of the sacrum. Is it tipped forward? Is it tipped posteriorly? And then your inferior lateral angles, which are shown in the inferior aspect, will tell you what's happening in the bottom part of the sacrum and the apex of the sacrum. So you get a ability to diagnose what the position of the sacrum is, as well as how it's going to move. With all the musculature in this area, you kind of need to consider what's happening in the pelvic bowl and on the inside. So when we address the lumbar spine, you think about the paraspinal muscles and you think about what's happening posteriorly, but you really need to consider everything that's happening anteriorly as well. And your psoas muscle specifically can cause a lot of problems because it's going to cross right over and traverse directly to the lower extremity. So it's really a low back muscle, even though it's commonly thought of as your hip flexor muscle, and it's sort of a hip muscle or a lower extremity muscle, but it's going to invest into all of the lumbar spine transverse process and over the anterior fascia in the lumbar spine. So problems in the lumbar spine with increased lordosis or any kind of side bending strain are going to directly affect what's happening in the hip flexors, and this can cause a lot of different kinds of problems. So we'll address this today. We'll kind of look at what's happening here. You've also got your pelvic bowl, your pelvic girdle, and the muscles that sling down inferiorly from the anterior aspect of the sacrum. So people can have a lot of problems with dysuria or dysmenorrhea or constipation and things like that that are directly related to excessive tension in the fascia and the muscles in this area. And just basic addressing of the sacrum can really help to release that. So you also just kind of see how the diaphragm's tied in with this, and superiorly you've got that layer overlying. And the ligaments are going to traverse right over your quadratus lumborum and your psoas muscle. So respiratory mechanics are going to be another thing to consider. And we're not going to get too much into that today, but problems with the rib cage, especially rib 12, are going to directly affect what's happening in this area and transmit to the lower extremity and the pelvis. So just a basic review of what we're doing. You've got your hamstring muscles touching onto your ischial tuberosities. These can throw off the way that the pelvis is kind of posturally aligned. If you have excessive tension on one side or both sides, it's going to limit motion of the pelvis because of the attachments there. And then gluteus maximus is also going to attach from the sacrum and the iliac crest onto the lower extremity. Tensor fasciae latae is going to come all the way down. That's an interesting muscle to consider because you're really attaching at the knee. You could end up having a dysfunction at the hip that transmits abnormal tension and strain onto the knee, and you've got chronic knee pain or ankle pain, and that's directly coming down from tensor fasciae latae. Well, you saw up in the upper extremity, and I think I have a slide to show this. Yeah, we'll get to a slide in a second. How this is directly related in with, connected in with those posterior wall mechanics, and you've got your rib cage, your quadratus lumborum, and those muscles coming down. The fascia, again, is going to be continuous throughout this entire thing. So the fascia is going to directly transmit down in through the pelvis and through the hip muscles to the lower extremity. And being such a long lever, the tensor fasciae latae can end up causing a lot of problems at the knee very easily with even just a slight abnormal motion at the hip. Hip external rotators, you've got a whole bunch of them. And I remember we learned P, Go, Go, Q in anatomy because you've got piriformis, gemellus, obturator, and then quadratus femoris. And that's not necessarily clinically important because they're kind of all melted in together and really even difficult to sort of differentiate and tease out in the gross specimen in the anatomy lab. But the big difference is piriformis versus the other external rotators is set up a little bit differently in that it has direct attachment onto the sacrum. So the mechanics that are happening with the sacrum will have more of a direct impact on the external rotators through piriformis than what's happening with the other external rotators. And it will cross that extra joint. So it can cause a lot more problems, and dysfunction there will be a little bit more evident clinically. You also have the sciatic nerve that will oftentimes pierce through the piriformis or just underneath the piriformis. So that'll kind of be a little bit differentiated, but either way, piriformis tension and spasticity can cause a lot of problems with compression on sciatic nerve and cause a lot of problems in the lower extremity. And that won't always be a piriformis problem where you've got pain in the buttocks area or in the sacral area. You can end up having just a radicular pain down the lower extremity, and you're not really sure if this is a lumbar spine problem or nerve compression at the level of the lumbar spine. But sometimes it can masquerade as a hamstring problem, and you kind of look at the hamstring and treat the area and you're not finding anything there, but it's a radiated pain from the piriformis, yeah.
Does it go as far as L5, S1? I mean, can it send it down?
Absolutely, it can send it down even past the knee. You can end up having radiating pain that goes below the knee. And
Can it be positional, like if you're prone? Or, I mean, supine?
a lot of times if the piriformis is spasm, can it be positional? It can be positional where certain positions can release piriformis. So if you've passively externally rotated the leg or the patient finds a certain position that helps, it can release that. But if the piriformis is very spasmed, it can just be constant. So it's a little bit difficult to tease out, and sometimes you need to, if it really does look like the person has a neuropathy at the level of lumbar spine, or maybe they have compression, you might need to MRI that. But if you treat them and they get better, it would be a lot easier to do that, a lot less expensive for the patient. And this is just so very, very common in so many patients, and actually very easy to treat. So we'll talk about that a little bit more in the lab. So piriformis, and this is just a little bit about piriformis syndrome. The other thing that can happen is trigger points can develop within the piriformis muscle. If it's had spasm for a long enough period, the myofascia begins to develop pathology and be more easily triggered, and it will stimulate a pain pattern and a radiated pain pattern over the area. So for some trigger points, you'll have a trigger point in a muscle, and the pain pattern is either distal or more proximal, or it's a little bit remote from where that muscle is. For piriformis, the trigger points are overlying right where that muscle is, so it's a little bit more easy to identify this as a piriformis problem when you have pain in the buttocks. Sometimes, though, you can see the pinkish area, it can radiate down over the posterior thigh. And so that trigger point might not even really be over the buttocks area, and it could throw you off just a little bit. But usually it's going to be right over the piriformis. So psoas, we talked about, you're going to compensate for imbalance here because it's a lumbar spine stabilizing muscle. So just kind of remembering what the attachments are here, T12 to L5, to the lesser trochanter of the femur. So you're crossing over the hip joint, but it's really a low back muscle, and will have a lot of dysfunction when there are faulty lumbar mechanics. So with spasm in the psoas, a lot of times the patient will come in kind of hunched forward and bent over that extremity because it's a hip flexor. When it's shortened and spasmed, they won't end up carrying their hip in flexion. They'll end up flexing the lumbar spine forward. So that might be one kind of signal, is how the patient's walking, what the gait looks like, or how they're standing as to what's going on in the lumbar spine. And actually, I've talked recently to some triathletes who have noted that from transitioning from the biking position, where you're here for extended periods of time, and then you immediately jump up to get into the running position, it can cause a chronic spasm in the psoas muscle, and it can cause problems in the initial portion of the run. And that's basically, you've kind of shortened the muscle when you're in the biking position and you're working it pretty hard. And then you need to kind of let that unwind and re-neutralize to a standing position before you initiate the next segment of the triathlon and begin running. But if you just think about what the mechanics are anatomically, that makes a lot of sense in how that muscle will develop shortening and spasm. A lot of times, because of the way this stabilizes the pelvis and the lumbar spine, this can be associated with a contralateral piriformis spasm. So if you kind of think of that tie-in, when you're treating one, you want to kind of address the other, especially if it's not really resolving and getting better and it comes back. You want to kind of think about, when you have piriformis spasm, what's going on in the contralateral psoas muscle. So Iliopsoas trigger point, and this is one of those that can radiate pain in a distribution that's not right over where that muscle is, so it might throw you a little bit if you're not very familiar with it. And trigger points are a really, really useful way to treat the body, in a sort of useful method to think through what's happening somatically. And I've got a flip chart that has the distribution on it and has the where the trigger points are in the muscle and where the distribution of pain is. It's not something you necessarily memorize unless you're using it very frequently, but these ones are really common, and it's probably a good idea to just be mindful of what may be happening. Anterior thigh pain can actually be from that ipsilateral iliopsoas. So you might want to kind of go there and address those lumbar mechanics and see what's happening. I don't think ever really focalize on a pain complaint and say, all right, what's happening in that anterior thigh? I'll always look at the very least at those surrounding mechanics in that area of the musculoskeletal system. But almost every patient I do at least a scan of kind of the whole body to see what's happening, because as I said before, you might have an upper extremity complaint, but the major part of the somatic dysfunction that's causing the faulty mechanics is in the pelvis or in the lower extremity. So it's really useful sometimes to do a once over and just kind of get a scan of everything before you kind of hone in and focalize on one complaint. But lumbar pain and anterior thigh pain can be trigger point referred from the Iliopsoas. And then I had mentioned before, and this just happens kind of commonly, you'll have patients with knee complaints or ankle complaints, and you focus in on those areas. It's a bad idea to do unless it's a patient who just had an acute injury of the ankle or an acute injury of the knee. That patient will have, whatever their typical postural discrepancies are, but now they've got an acute strain and they torque the knee or they torque their ankle. So you could just treat that knee or treat that ankle and get them back to their baseline, maybe treat them a couple times and get them back to their baseline and they're fine. But almost always when you've got a chronic complaint, there are established baseline postural dysfunctions and somatic dysfunctions that are already present. So if you just go to that knee and treat the knee, the likelihood of that getting 100% resolved is pretty low. You could have that knee pain that's coming from, as I mentioned before, abnormal pelvis mechanics and innominate mechanics, where the pelvis is just a little destabilized and rotated in an abnormal position, and tensor fasciae lata is not set up mechanically to transmit that force in the correct direction. So it just puts a little bit of torque on the knee and they end up having, faulty knee mechanics. If you focus only on the knee, you're going to completely miss that. And it can be so simple where you just kind of realign the pelvis and they're 100% better. So it's really worth kind of thinking more globally, especially for chronic complaints. So this was kind of an interesting way to show. You've got Quadratus lumborum attaching to rib 12, and that fascia is going to come right through those pelvis muscles and through the hip muscles and transmit down to the lower extremity. It's one really fascial band that comes all the way down, and an abnormal force put through any aspect of that fascial band can transmit those forces to other areas. So it's important to kind of consider all of that. Trochanteric bursitis a lot of times can be involved with problems here where those bursa get inflamed. So when they have hip pain, you want to kind of think of that. They will usually have pain directly over the greater trochanter. And that can be kind of a chronic problem, and there's a lot of inflammation there, so you treat and you get things reestablished and you release the strain in this area, and they may still have a little bit of tenderness there that's left, and that can take a few days to resolve. If you resolve the underlying somatic dysfunction, it should resolve that extra tension that's being put on that area and allow the bursitis to continue to resolve, and they may need some NSAIDs or some medication in the meantime if it's very, very severe, which sometimes it can be. But you got to just kind of tell your patient, like, let's let this underlying inflammation kind of settle down. I think we've got your mechanics reestablished, and it should stop flaring that up. So you kind of have them follow up in a few days or a week. Okay. I think I've kind of noted everything we needed to say there. Lumbar plexus of nerves, you can have somatic dysfunction that will affect the lower extremity through the nervous system also. So you think of the muscles and you think of the fascia, but you directly can put force of compression through the fascia in the musculoskeletal system that will abnormally compress nerves and cause dysfunction of the nerves. And the interesting thing about the nerves is you've got the axons that start and come all the way down, and it's a pretty long cell body. When you have abnormal mechanics or strain or compression and the proximal aspect of a nerve, you sort of make that entire nerve sick distally. So that if you've got a little bit of fibular head, fibular head's abnormally positioned, you can have a neuropathy that's happening way distally in the leg. But that's maybe not a very significant dysfunction. That nerve may not be sort of in a healthy position because of the lumbar spine mechanics to begin with. Yep.
What does SD stand for?
Somatic dysfunction. Thank you for clarifying that. Somatic dysfunction at the lumbar plexus can affect the lower extremity. So what I'm wanting to say there is sometimes you've got a little bit of a dysfunction distally, but if that nerve's already unhealthy because of what's happening more proximally, you need to address what's happening in the lumbar spine as well as maybe that fibular head that's abnormally positioned and compressing on the peroneal nerve. The problem may not be entirely distal. So they may complain primarily of problems in the legs and not necessarily lumbar pain. You've got to address what's happening in the lumbar mechanics to allow those nerves to be healthy, and because the radiation could entirely come from the lumbar spine. Okay, so this is a really interesting case, and I put this in to sort of prompt me to remember to discuss it. But I had I think it's about a 50-year-old patient who came in to see me and was having a little bit of lumbar pain. He was having anterior right thigh pain that was severe, but it was a hyperesthesia where even just touching the area would send a severe amount of pain. It was very, very sensitive and kind of tingly for, it was about 3 or 4 weeks at the point where he saw me. He had seen his primary doctor, who's an internal medicine physician, who then sent him to an orthopedist. And he had a little component of back pain along with this. And he kind of considered what might be going on and looked at the hip and looked at the back and really couldn't find anything wrong. So we had him do a couple exercises and nothing was really getting better. He then developed radiation of this pain in the right testicle. It wasn't actually radiation of the pain. He developed right testicular pain. And he was sent to a urologist. And the urologist evaluated him and thought he might have something, an infection or epididymitis or something going on with the testicle. Ultrasound was normal. He did a urinalysis, and that was actually clean. But he was put on antibiotics. And I think the urologist kind of didn't really have a paradigm that fit why this person would be having testicular pain, other than maybe there's an occult infection that I'm not seeing on the urinalysis. Urine culture was negative, so the antibiotics were not really warranted, but sometimes when we don't have the tools to deal with what's there, you kind of find a creative way to use the tools that you do have. It's not necessarily a great way to practice medicine. And I don't think this physician maybe had the ability to put together what might have been causing the testicular pain. So that was kind of a dead end there, and the testicular pain continued. He also developed fatigue in his right lower extremity, and he couldn't really explain that, but this guy was really fit and really athletic. He's working out all the time and running. And he said, yeah, when I run, he noticed his gait. He didn't vocalize this, but his gait mechanics were thrown off. He said, didn't feel right when I run, I get really fatigued easy. And he noticed that right leg was getting more easily fatigued and sore. So it kind of sounded like a claudication kind of thing. So I evaluated him, and he had a huge pelvis, a shear in the pelvis, where it was kind of torqued into one position abnormally. And I kind of considered the anatomy, and I'm like, what's happening here? And when you do have a paradigm, which we do, thankfully, that can help tie things in together a little bit more globally, and you look at all the different symptoms a patient's having, and you put them together holistically, you can come up with a way that this does make sense. So he was actually compressing over the anterior pelvis on the inguinal ligament, and all the underlying structures were compressed. So the femoral nerve was being compressed. There's a genitofemoral branch that will go into the testicle. That was being compressed and was stimulated, and he was having that testicular pain. He also had, so the anterior thigh pain and hyperesthesia could be very easily explained by that. And then he was compressing. You've got your nerve artery vein right in that area. So you might have been experiencing a little bit of claudication and fatigue because of the compression of the nerves, but it also could have been a problem with compression of the arterial supply to the lower extremity. So I addressed him and treated this underlying lumbopelvic strain, and he got about 80% better after the first treatment. And I treated him a total of 3 times, and he completely resolved, which was great. And at one point in the evaluation, he said to me, the orthopedist asked, so he had actually seen an orthopedist, a neurologist, a urologist, and his primary doc, so it was 4 docs in about a month before getting to me. And no one had really an ability to give a good treatment that would help. So he said to me at one point, the orthopedist asked me if I've been doing any heavy lifting and asked me a bunch of stuff like that, and I haven't really been doing any lifting. And I said, well, don't you work out all the time? And he goes, yeah, that's what I was just thinking. There's this new leg press machine I started using. So you lie on your back and you press your legs, away from you. You're not lifting anything, but you're definitely doing the same mechanics, and it was a huge strain, and that kind of explained just what happened in his lower back. And this happens very commonly once you treat something and you connect in the somatic dysfunction and release it. The memory of that strain will immediately come back, and they're like, you know what? There was this one time when I twisted this way or I picked something up, and he remembered, he told me, that strain he had with that new machine and what he was doing with his lumbar mechanics once we kind of got in there and you're feeling that. So that was is a really interesting story, and you know, you won't always kind of get the history. You have to be really creative. We tell the students all the time, you've got to ask the question 12 different ways sometimes to even find out if that person has any past medical problems. But some things like this will elude you a little bit, and it was kind of an interesting story, an interesting case. Okay, so this will just show overlying your psoas muscle and overlying your the anterior aspect of the lumbar musculatures will be your lumbar plexus of nerves. Yeah.
What does LE stand for?
Lower extremity. Thank you. A lot of times I use these in teaching in the medical school, and we'll, you know, these are old hat at that point, so we've shortened, but thanks for clarifying. So these are the nerves to the lower extremity, and your lumbar plexus, femoral nerve, obturator nerve will course anteriorly over this musculature. So a lot of times, even though you may have a neuropathy and think that this is primarily a nerve problem, it can be because of a fascial strain or a muscular strain in the way that it's putting excessive compression or just causing inflammation and stimulation of the nerve at the level of the lumbar spine. Lumbosacral plexus, so sciatic, is going to go to your posterior thigh muscles and your muscles of the leg and foot. So the lumbar plexus will do more anterior thigh and upper leg. Lumbosacral plexus will do your sciatic and lower leg. So posterior thigh and lower leg. And this just shows what's happening underneath that inguinal ligament. So navel, nerve, artery, vein, and then empty sac with lymphatic tissue is how we learned it. And I always remember you're walking toward the navel as you spell. So if you're on the right versus the left, you have to remember which way you're spelling toward. For example, if you're doing a femoral line or something like that, you want to remember the orientation of this anatomy. And that's pretty much what was happening in this patient and the complaints that he was having. So viscerosomatic considerations I'll just touch on briefly. Your visceral disease, you can have a problem in the uterus or bladder or something that's irritating these areas that can manifest as a somatic dysfunction or a somatic complaint with low back pain or physiologic change that causes spasm and abnormal mechanics in the lumbar spine, the pelvis, and the sacrum. But you have to also remember that those somatic dysfunctions, the dysfunctions that occur in the musculoskeletal system, will affect the nervous input that's going back into those levels of the spinal cord, and that spinal cord can become what we call facilitated or a little bit flared up at the level that the nerves go out to the viscera, and that can flare up and cause problems with the underlying viscera. So you have your somatovisceral dysfunctions, somatovisceral reactions, and you have your viscerosomatic reactions. And with the viscerosomatic, you need to consider when you've got low back pain and you feel what's happening in the somatic system and you get it better, and then it comes back again, and then the same kind of setup is happening in the somatic system, and you treat it again, and it comes back a few times. So you might want to consider what's happening and what's the underlying imbalance there. Is there a visceral pathology that you need to consider? It's a really wise thing to always do a review of systems for the viscera, the organs. Are you peeing and pooping okay? Are you eating and drinking okay? And just kind of, even if it's just a basic complaint of low back pain or pelvic pain or anything, because sometimes you just kind of catch things like, well, you know, when I eat, I get this heartburn, or well, I'm usually really constipated. And things like that are really common, and they may actually resolve after one treatment of the musculoskeletal system because you release that tension in the pelvic girdle, you release what's happening that's causing tension in the diaphragm and can cause abnormal movement of the food when you're swallowing, and can release some symptoms of GERD or heartburn. But you want to kind of note that, because then on the next visit, if the somatic dysfunction comes back, you might want to probe more fully into those visceral complaints. So areas that feed into the lower thorax are going to be affected by lumbar mechanics, upper GI tract, small intestine, pancreas, as well as your pelvic and abdominal organs. So your sympathetics come from T1 to L2, and then your para are around, so cranial and sacral. So especially in this area, we're dealing with a lot of issues with the parasympathetics, but then those lower portions of the sympathetics are going to be tied in with the lumbar spine. And as I mentioned, everything's connected together. So when there's excessive strain in the lumbar spine, you're going to affect your thoracic spine as well, and you can cause problems with the sympathetic nervous system, of course. So like I said, sometimes you'll treat and these other complaints that you hadn't really even specifically addressed may release and resolve and get better as well. But specifically with the parasympathetics, you want to think about gut motility. You want to think about the sex organs, the kidney and the bladder. I had a patient a couple months ago who had severe dysuria and was treated with antibiotics, and she kind of had this recurrent cystitis that wasn't, it was an inflammatory cystitis, non-infectious cystitis, and we couldn't really figure out what was going on. And I treated her actually after the first treatment and released a ton of congestion and tension that she had in her pelvic sling, the muscles of the pelvic girdle, the pelvic sling, and released that. And she was almost completely resolved after the first treatment. And then I treated her again, and it was it was completely resolved after the second treatment, 100%. But she had been on multiple courses of antibiotics, and she even developed hemorrhagic cystitis. She was so inflamed. So the history with this patient was she had had a bladder attack a few years back because of, there was too much laxity and she was having incontinence of urine, so they tacked her bladder back up. I had her do Kegel exercises just to strengthen the pelvic musculature, but I think with that bladder attack and the scarring that had occurred around the bladder and the uterus, she'd had just an abnormal strain that didn't allow this area to sort of live and breathe normally. So the blood flow that's getting to the bladder and the drainage that's coming away from the bladder wasn't as harmonious as it needed to be, and releasing of that strain that had been kind of developing there really helped very significantly. So colon and rectum will be tied in down to L2. Kidney and ureters will be tied in, and I just kind of highlighted what parts of the lumbar mechanics will affect these organs. Urinary bladder, testicle and epididymis, as we had with the patient that I had seen, he's having some problems there. Uterus and the prostate, these will all be involving sympathetic nerves from the lumbar spine. It's really always really interesting to me to consider the anterior abdominal wall, because we kind of forget this area a lot, and a lot of people focus, we have low back pain, let's focus on what's happening in the low back. But it's important to consider, there are even trigger points that happen along the rectus abdominis that will cause pain in the back. The triggering area of pain referral is going to be in the lumbar spine. And you can address very easily what's happening in the fascia and the anterior abdominal wall and release that and help to relieve that chronic low back pain. But mechanically, it's really important. When you adjust your pelvic mechanics in a certain way and your pelvis is tipped forward, the nervous system is not innervating that abdominal wall in a normal way. The tone that's established there doesn't happen normally. So you have laxity of the anterior abdominal wall. Well, once you have laxity and you have that sort of forward tilt of the pelvis, the abdominal wall musculature can protrude forward very easily. This actually contributes to the weakening of the abdominal wall because it's getting stretched abnormally, and the likelihood to develop herniation is much higher. You also can develop a pot belly and congestion in the pelvic and abdominal organs because of this. What's supposed to be happening, and what happens with respiratory mechanics, is the diaphragm descends and compresses on these intra-abdominal and intrapelvic organs. So all the fluid and the venous fluid and the lymphatic fluid and the waste products actually get kind of squished back up, and through that opening in the central tendon come back up through the lymphatic channels and the inferior vena cava. You need appropriate integrity of the anterior abdominal wall in order to sort of allow that increased intra-abdominal pressure to occur. If you have excessive laxity in the anterior abdominal wall, it just sort of pooches the abdomen out. And with faulty breathing mechanics, you're not going to sort of take advantage of that cleansing mechanism that's meant to happen through the respiratory diaphragm, through the establishment of that negative intrathoracic pressure to allow that fluid to sort of suck back up, back to the heart. So if you have increased compliance in the abdominal wall and it just kind of pooches out with that increased abdominal pressure, you're really limiting that function to sort of cleanse through the lymphatic and the venous system and to cleanse through the organs. So, and I didn't put a picture in here, but a lot of times I will, there's two guys kind of making a joke about their pot bellies, and they got these big beer bellies. And a lot of times people think of increased abdominal fat, or that patient needs to lose some weight. But you'll see very often in even very slim individuals that the abdominal wall can pooch forward, and that tonicity that's supposed to be established there isn't happening. So if you end up, and we'll do this, actually let's do it now. Everybody stand up. Since it's early in the morning, might as well just wake up. So stand, get your feet kind of parallel, hip distance apart. And let your abdominal wall pooch forward, so your belly button comes forward. Increase your lumbar lordosis, so you're arching your back. And put your hands on your lower abdomen. Now, do the opposite and flatten out your lumbar spine like you're pressing it back against the wall. And what you should feel is that increased tone in the anterior abdominal wall. Kind of automatically happens. That's a function of the stabilizing muscles in the low back. They automatically innervate the anterior abdominal wall. That's a fascial thing that happens and a neurological thing that happens to establish tone in the anterior abdomen. You actually, and if you breathe this way and just take a few deep breaths with your hands on your abdomen, you'll feel those mechanics and what's happening in the anterior abdomen, and you'll get more energized through the breathing, because you're flushing out all that fluid back to the heart. Then let your abdomen tip forward again and do a few deep breaths there. It's really difficult to inhale. I think I'm on another slide for this. It's more difficult to inhale because you're not in that appropriate thoracic mechanics. Kind of tip yourself back and flatten out the lumbar spine. We got to end on a good note. And take a few deep breaths there. It should be easier to inhale, and it's actually more energizing because your system's set up in a more appropriate way mechanically. Anybody not feel that? All right, have a seat. Thank you for doing that exercise for me. So that's one thing I will focus very, very heavily on with my patients is postural mechanics. So structural exam, what's happening in the thoracic kyphosis, cervical lordosis, and lumbar lordosis, and where is that pelvic bowl sitting? So if you think of the pelvis like a bowl, you don't want the water to tip forward, you don't want the water to tip back, you want to hold the water right in the bowl. That's actually what's happening within the body energetically, is your energy ascends up the spine instead of sort of pouring out. And you can feel that when you're standing and what's happening with your nervous system. So pubic and innominate somatic dysfunctions, you get different things that will happen, and these are really simple with the pelvis. You're going to rotate anteriorly and posteriorly on one side versus the other. You can shear superiorly or inferiorly in one innominate versus the other, or you can flare in or out. The ASIS will come medially or laterally on one side versus the other. And you need to diagnose which side is the faulty side in order to know what's happening. So we'll talk about that in the lab as well. And then the pubic bone can shear. So you get this sort of shearing inferiorly or superiorly of the pubis, and that's not really a physiological motion that should happen. When we're walking, the pelvis is moving and the innominates are moving relative to each other, and you have this flow of motion. That's normal physiologic motion. And it can get stuck and cause somatic dysfunction because it's a little more torqued into one position. Especially with the way that people stand, it might be a little more rotated or flared on one side versus the other. But the shear is not a physiologic lesion, and those will usually be more apparent clinically. So this shows what's happening with the rotation. ASIS will be anterior, PSIS will be superior, and we'll go over this in lab a little bit more fully. If you have a posterior rotation, PSIS is inferior, ASIS is superior, so you just kind of think mechanically of how the pelvis is rotated. And then a shear, the whole thing is higher or lower on one side. And if it's higher, you can yank it back down and make it lower. And if it's lower, there's some muscle energy techniques we can do to press it back up and make it higher to balance out the innominates. And then the flare. Where is the ASIS relative to the midline? So you look at your xiphoid process, or you look at the umbilicus, and you look at how that ASIS lines up. Is it flared out laterally? Is it flared in medially? And you get a sense of what's happening. Now, if you just see that the right one is further away from the midline than the left one is, you don't know if that's a left medial flare or a right lateral flare. You need to diagnose which side the dysfunction is on. And then we talked about the pubic shear briefly. What will happen there is one side will come higher relative to the other or lower relative to the other at the pubic symphysis. And those will usually be, you know, the patient steps off the wrong way on the end of a curb and didn't see the curb, and then you kind of like jam into the pelvis. Usually those aren't going to be just your normal postural mechanics causing a somatic dysfunction. Usually that's a little bit more of an incident or acute injury. So to diagnose the innominates, you want to see which side the lesion is on. And if you put your hands with your fingers on the PSISs and then you have the patient bend forward, you do the standing flexion test. And we'll go over this in lab to get an idea of how we diagnose. And you just compare which PSIS moves forward first. And basically the way that I thought of it when I learned this is if it's stuck on that side, the lumbar forward bending will carry that PSIS forward because it's lesioned on that side. So the one that goes forward with the lumbar spine is the faulty innominate. The one that stays and stabilizes and allows appropriate range of motion where the lumbar spine moves and bends forward, and the pelvis innominate has its own motion and can stay stabilized before eventually it moves forward too. That's the one that has more appropriate mechanics. So the lesion side is the one that moves first or goes furthest anteriorly when you have the patient bend forward. Sometimes hamstring hypertonicity can kind of throw this off because the hamstring pulls the opposite way. It's going to be pulling on the on the ischial tuberosity, and that will prevent that innominate from moving anteriorly, and that can be a clinical consideration. So briefly for sacral mechanics, your sacrum is going to move relative to your SI joints and relative to your lumbar spine. So with all that ligamentous sort of meshwork we considered, it's kind of slung in there, and all of those ligaments are kind of holding it and stabilizing in place. So there's this transverse axis at the level of S2 that allows it to rotate forward and back. The base moves anteriorly or moves posteriorly. And that happens with mechanics and with walking and with moving and with bending the lumbar spine. And that also happens with breathing. So there's nutation or flexion, where the anterior aspect of the sacrum goes forward. And then there's extension or counternutation, where the base of the sacrum moves posteriorly. And that's what you want to think about is the sacrum moving normally into nutation and moving normally into counternutation, or is there a lesion where it moves easily into one position, but it doesn't move very easily into the other position? So if you have a flexed sacrum, you end up having that sacral base anteriorly, and it doesn't want to move posteriorly very easily. And you'll find that diagnosis in a couple different ways that we'll do. With normal lumbar spine mechanics, you have that physiologic lordosis, and that allows the sacrum to be in a relatively nutated position. Increased lordosis is going to be an accelerated and enhanced sacral nutation, sacral flexion. So the base of the sacrum is going to be more anterior when you have excessive lumbar lordosis. In the standing position, you develop a little bit more of a lordotic curve. That enables the sacrum to move into flexion. The sacral base moves anteriorly. In the seated position, you flatten out the lumbar spine, and that allows the sacrum to move into counternutation. But if you're stuck in any one of these positions, either through the sacrum or through the lumbar spine, faulty mechanics, you'll lesion that sacrum into one position or the other, where it doesn't move as freely into the opposite position. So you need to think about the lumbar spine kind of in conjunction with the sacrum when you're trying to induce this motion and treat this area. So a lot of times a patient who has a counternutated or extended sacrum, they may be more comfortable when they're in a seated position, because that allows flattening of the lumbar lordosis, and the sacrum will be comfortable in counternutation. But then they go to stand, and it's kind of stuck. It's stiff, and it does not want to move into nutation or flexion. So sometimes the standing versus seated complaint that the patient has can give you a tip onto what's happening with the sacrum. So again, if they're more comfortable standing, that may be because the sacrum's comfortable in flexion, but they have pain sitting, it doesn't want to move into extension, or vice versa. And these are the ligaments that are going to be affected. And you can palpate over these ligaments and see where there's increased tension or tautness, and palpate what's happening. And the other thing that we do is we monitor over the sacrum and have the patient breathe. So I'm going to discuss also what happens with respiratory mechanics. One of the things you can do with a static diagnosis is to have your hands in the sacral sulcus. Now, if the sacral sulcus is deep bilaterally, that means that sacrum will move fluidly into flexion or nutation. If it's shallow bilaterally and you press down and it feels hard like a rock and it won't move anteriorly, that may be because the sacrum is bilaterally extended. And then you can have a unilateral flexion or a unilateral extension where one side is nutated or counter-nutated and resistant to motion. And we'll talk about that in lab 2. So the sacral sulci, you need to make your diagnosis there, and then the inferior lateral angles. If you've got a flexed sacrum, the inferior lateral angles are going to be more prominent. They stick out posteriorly. And if it's extended, you'll get some motion there when you push on them. Okay, so this is an important little point to mention. When we have inhalation, the spinal curves will flatten. So you have a decreased lordosis, decrease thoracic kyphosis, you flatten out the spinal cords on the inhale. Well, what's that going to do to the sacrum? When you decrease the lumbar lordosis, your base of the sacrum moves posteriorly, so you're going to counternutate the sacrum. So the sacrum moves into extension on the inhalation phase of the breath. On the exhalation, you relax and the spinal mechanics are restored or enhanced. So you increase your lumbar lordosis and you allow the sacrum to move into nutation or flexion. So the base of the sacrum moves anteriorly on extension. So you can use that respiratory pattern to enhance the motion of the sacrum in either direction. And we talked about seated versus standing. So we palpate over the sacral sulci, we palpate over the inferior lateral angles, and you don't just get a static palpation, you press in there a little bit and see what is this motion going to allow. How much motion will the sacrum allow when I press? The other thing you can do is put your hand right over the sacrum when the patient's in the prone position, and you have them inhale and exhale. And we'll go over this in lab, but when they inhale, it should allow the sacrum to counternutate or extend, and you should feel that fluid motion. When they exhale, it should allow the sacrum to flex. And if you're feeling that with the respiratory motion, you can begin to easily diagnose where there's a little bit dysfunction, and you just allow your hand to kind of compress into the direction you want it to go in and allow them to breathe into that, into whichever direction to enhance that motion. And I'll show you how to do that today. So these are the different lesions that we can have. We're not really going to talk too much about torsions, but I put it in here for your own review if you want to go through that, because there's some sort of simpler ways to get more familiar and review with the torsions that might help you kind of be able to diagnose and treat these more easily, but it's a little bit, I think, more advanced than what we're going to do today. Seated flexion test will help you diagnose the sacrum. Same thing as standing flexion test. You're going to put your hands onto the PSISs, but now you've stabilized the innominates. So the forward motion of the lumbar spine will be transmitted into the sacrum, and you'll feel the pull of the sacrum on the innominate, and whichever innominate moves forward first is the one that's restricted at the SI joint. So same kind of thing we do with the standing flexion test, but this will help diagnose abnormal motion at the SI joint. And then for our treatment, we'll use the forces of respiration to augment the treatment. As I said, inhalation will bring the sacrum into extension. Exhalation will allow flexion, and we'll talk about that in lab. These we'll do upstairs. I don't know if I'll be able to show you the slides, but I think we'll be able to have the, the students, thank you very much for your help, show you. Yep. We'll have the students kind of come around so they can show you what we're doing. And I'll cut into just a couple minutes of my lab time for the sake of showing you this, because I think it will help make it a little bit easier. We're going to use the palm of the hand to press onto the sacrum and either enhance flexion or enhance extension. And I'll show you what aspects of the sacrum to push on, but you'll have the patient breathe, and you'll augment that respiratory motion and augment the motion that's happening in the sacrum with your hand. If you do a unilateral treatment, you just focus your forces on that half of the sacrum. And what we'll do often is we'll bring that one leg into abduction, just bring it a little away from the midline, and then you internally rotate. And what that does is it gaps that ipsilateral SI joint, so you get a little more sacral motion with the respiratory mechanics, and your forces will enhance the sacral motion a little more easily. When you internally rotate, you gap the SI joints. That allows you to kind of release that tension there. So we'll use that a little bit when we treat. And the other thing we can do is a muscle energy treatment. We have the patient sit and arch back, or they sit and they bend forward. And you just help them stretch into this position. And I think we'll probably be able to get to this one today. You're pressing into the sacrum to help it move either into flexion or into extension. So if you're going to have the patient flex forward, that helps extend the sacrum. And you can see on the left side, the base of the sacrum, the superior aspect of the sacrum, moves posteriorly. When you have the person arch back, you're helping to flex the sacrum. The base of the sacrum is moving anteriorly. Torsions, as I said, we're not going to really get into too much because there's a lot of complexity, and we don't really have that much time. But if we have time in the lab, we might talk a little bit about this. But that's for you to basically review. And then A.T. Still's quote, keep in your minds keep your minds full of pictures of the normal body at all times while treating the afflicted. This is one important thing I always remember is when I learned osteopathic manipulation in my fellowship at Unicom, we always were taught focus on the health, find the health. And one of the teachers I had was Jim Jealous, and he always would say, find the health, where's the health? Because you want to focus on that and help it to expand into the body. As soon as you start focusing on the disease or the pathology or where it's not moving, you shut everything down, you're not allowing anything to open and expand. So you always find the breath or find the health or find the motion that is present in the body, and then help that move into these other areas. And it's a really simple thing when you think of things fascially, that it'll just stretch into those areas little by little. But if you find where there is motion and when there is health, and you allow that to, you allow yourself to just do what you need to do to enhance that, it's always a good starting place for rebalancing and treating the system. So thank you very much for coming so early to my lecture, and I'll see you in lab.